Hi there. Today we're shining light on a critical but often overlooked public health issue. And joining me today is Dr. 𝐷airo Gbolahan, the Medical Director at 𝐓𝐻𝐻 Foundation Nigeria, an organization focused on combating diseases like tuberculosis and leprosy in Nigeria. What is 𝐓𝐻𝐻 Foundation?
Yeah, 𝐓𝐻𝐻 Foundation is a medical non-profit organization based in Nigeria, but affiliated with the 𝐓𝐻𝐻 Foundation Belgium. We've been supporting TB and leprosy control program in Nigeria as far back as 1999.
So what exactly do you do in Nigeria?
Yeah, we offer technical support to federal, state, and local government TB and leprosy control team.
What does your role fit into that work on a day-to-day basis, sir?
Yeah, I'm the medical director of the organization. I coordinate the implementation of TB and leprosy activities in the office as well as on the field. We support the federal, the state, as I've mentioned earlier. We offer technical support to the implementation of all activities that has to do with the two control programs in Nigeria. But we covered the southwest part of the country, including Kwara State.
So thank you, sir. So help us understand the scale of the problem. How serious are leprosy and tuberculosis in Nigeria right now?
Yeah, for TB, Nigeria has the highest burden of TB in Africa and sits globally among the 30 high burden countries in the world. And the Nigerian TB program reports on annual basis over 400 cases of tuberculosis. And the other thing about TB in Nigeria is that Nigeria also has the highest burden of drug-resistant TB. I can say in Africa, as well as 8th globally. So also the TB HIV aspect of it is also worrisome, because presently the co-infection rate on TB HIV is 27%, which is on the very high side.
So, sir,
for leprosy, although Nigeria has reached elimination level as far back as 1998, but we still have pockets of endemicity in some states in Nigeria. And I can tell you right now that we have more cases in the northern part of the country, but we still have pockets of endemicity in the southwestern part of Nigeria. So also we have high grade 2 disability. What I mean by grade 2 disability is that most of the leprosy patients being detected, they have come down with deformities. And I can say that averagely in Nigeria, we have 14% grade 2 disability, which is more than 5% recommended by WHO.
So, sir, are we seeing progress, or is there still a long way to go?
Yeah, we are making progress in terms of case detection and treatment in Nigeria. But we still have some challenges in the two programs. For TB, we are underreporting. I mean, we are not actually getting the actual number of cases we are supposed to report annually. So also we are missing some cases due to some associated factors, which I'm going to mention now. The first one is stigma. The two diseases are highly stigmatized, and that prevents patients with those two diseases from coming out for diagnosis as well as for treatment. So stigma has been a big problem in the control program of the two diseases. So also we have staff attrition. I mean, most of the trained staff, they've now left the service. So we are left with newly untrained officers working on TB and leprosy control program on the field. So we really need to build their capacity to be able to make a prompt diagnosis and give adequate treatment on time. So also the control program for the two diseases is donor driven. We have for TB, with the help of Global Fund, we are able to achieve a lot. But for leprosy, the whole program, the whole leprosy control program is donor driven. So without assistance from outside, there won't be any leprosy control program in Nigeria. So these are the issues that we need to tackle when we want to sustain the program in future. So also, we also have, in leprosy, we don't care for patients after cure, which is very important because majority of them, they have deformities, they are disabled. So we really need to take care of their immediate problems as they arise. So I can tell you that presently we have few organizations in Nigeria that are taking care of people affected by leprosy after cure. And Damien Foundation is playing a very big role in this area of care after cure. So I think those are the major challenges we have in the two control programs.
So who are the most vulnerable groups affected by these diseases?
Yeah, the most vulnerable groups affected by the diseases are as follows. It affects people in the productive age group, between the ages of 14 years and 45 years. Those are the age groups that goes out on daily basis to fend for their dependents. The children, they are above 14, they attend schools, they go out and look for other things to support their families. And another vulnerable groups are the people affected by HIV. You know, HIV fuels TB because HIV has to do with depression of one's immune system. And once somebody's immune system is depressed, TB also be very happy to thrive in such environment. So HIV, people with HIV are likely to come down with TB. So also children below 14 years, they are also vulnerable because of their low immune status. Then another group are the drug users. I mean, they are also very prone to TB as well as leprosy. Then poverty, those who are poor because of their nutritional status. They have a very poor nutritional status. And majority of them, they live in overcrowded environment. They are also likely to come down with TB. Those with other medical conditions that reduces one's immune system can also, TB can also thrive in such individuals, like diabetes, people with cancer or terminal illness. Because of their poor immune status, TB is likely to thrive in such individuals. Then the other group, people with anemia. Anemia, they are also likely to come down with TB.
So what makes you different? I mean, there are many organizations in the health space. What makes your approach different?
Yeah. I want to tell you that our vision is a future or a world with free tuberculosis and leprosy. So also our mission is also to make a difference in the fight against the two diseases. So what makes us different from other organizations in Nigeria? I can say that a partnership is one of the key things that we really enjoy in our approach to the TB and leprosy control program in Nigeria. We partner with many organizations, community-based organizations, the opinion leaders in the community, the missionaries, students of our institutions, the World Health Organization, and other key partners that are really fighting TB and leprosy in Nigeria. Then, another thing that I want to tell you is that we always like to take lead in anything that has to do with reduction in the burden of TB and leprosy in Nigeria. The 𝐴𝐵𝑁 Foundation happened to be the first organization to treat multi-drug resistant TB in Nigeria. We started the journey as far back as 2012. And I can tell you that we are the leading organization in Nigeria in the management of multi-drug resistant TB in Nigeria. We started the program at University College Hospital in Ibadan then. And I can tell you that because of our approach to the drug-resistant TB in Nigeria, we assisted the national program to cover all the states in Nigeria for the treatment of multi-drug resistant TB in terms of capacity building. We built the capacity of all, I can say that 90% of health staff, health professionals in Nigeria were built by our 𝐴𝐵𝑁 Foundation. So also the first multi-drug resistant TB ward in Nigeria was constructed by 𝐴𝐵𝑁 Foundation at UCH. So also we pioneered the community DRTB in Nigeria. Before now, we were not managing drug-resistant TB in the community, but some time ago we pioneered the approach, the innovation, and I can tell you that at the moment, majority of our patients are being managed in the community. Another thing that we did, and the first of its kind in Nigeria, is that we were the first organization to use sputum dispatch riders in Nigeria. I mean, the transportation of sputum from the clinic to the laboratory has been a major problem in Nigeria. But sometimes in 2016, in Lagos, we pioneered the sputum shipment from the clinic to the laboratory with the use of sputum dispatch riders. And another thing that we did that has never happened in Nigeria is that the sputum shipment, we were able to monitor it real time with the use of electronic dashboard. And I'm happy to tell you that it was adopted by the national program and is being used all over the country. So all the 36 states, including the Federal Capital Territory, they are now using the sputum dashboard to monitor the sputum shipment across across Nigeria. So that's another feat. Then for leprosy, we happen to be the first organization that started the mobile clinic initiative for people affected by leprosy in Nigeria. Because of the issue of stigma, they couldn't attend the normal clinics, the government clinics that we have around. But we were able to manage to establish a mobile clinic, a monthly mobile clinic, where we attend to them as the settlements. And we will always take care of their medical conditions like malaria, hypertension. Then we also manage their ulcer. We do ulcer care. Their wound is being managed on a regular basis. So I can tell you that, it was showcased to the international world sometimes ago in China. And people were very happy with the initiative of the mobile clinic. Then the care after cure programs is also one of the feats achieved by the 𝐴𝐻𝐻 Foundation. Care after cure has to do with physical rehabilitation. Many of them, they are incapacitated. They have amputated limbs. They can't move about. And they are also down with disabilities, all forms of disability, claw hands, claw fingers, claw toes. And we were able to set up a reconstructive surgery center at 𝐓𝐻𝐻, where we do a reconstructive surgery for those with deformities that are amenable to surgical corrections. So, and everything about the place, admission, feeding, surgery, surgical fees is free once you are a leprosy affected individual. So we don't charge them. And patients are welcome from all over Nigeria, from the north, from the east, from the south. Once they get to 𝐓𝐻𝐻, then we offer them free surgical intervention. And we also support their transportation, irrespective of their location in the country. We support their transportation to and fro from their home to the center. We did that in partnership with the Bowen University Teaching Hospital at 𝐓𝐻𝐻. So we trained 2 of their health professionals, 1 medical doctor and 1 nurse for surgery as well as physiotherapy in one reputable hospital in India. So that was done in the year 2016, to be precise. And since then, the people are people affected with leprosy. They've been enjoying free surgical intervention. Apart from that, we also attend to their other medical needs. We take, especially people affected with leprosy, once they are down with any illness, the 𝐴𝐻𝐻 Foundation, especially the people in our coverage area, we pay for the hospital fees, admission fees, for drugs, everything. So they don't pay out of their pockets for any of such services. I think those are the things I can remember for now. We still have a lot to discuss.
Yes, sir. Thank you very much. So I was going to ask, can you share a story that brings your work to life? Any story that comes to mind.
Yeah, we have so many success stories. But for community, for the leprosy settlement community at 𝐓𝐻𝐻, I can say that what the intervention of the 𝐴𝐻𝐻 Foundation in that community has really improved their quality of life. When we got there in 2011, to be precise, we did an assessment visit to the place, and we found out that they were living in they have like 7 camps. And in one of the camps, the people living there, they are incapacitated. They can't move from point A to point B. They lived on charity. So we decided, and that camp, incapacitated, they call it incapacitated camp. It was our first place of port of call for the intervention that we did at 𝐷𝐻𝐻. We did some other things at that time, but at that camp, we renovated about 7 blocks of rooms in that place, and we furnished the rooms with mattresses, beds, and chairs. Then we also noticed that they did not have toilets and no pipe-borne water, no potable water for their use. So we constructed toilets, the modern toilets, as well as we built kitchens for them for their use. So also we sank a borehole, and it was connected. We ran a pipe to the camp so that everybody living in that place can have access to potable water. And I can tell you that then we bought a generator because the camp was not connected with the national grid. There was no life in that place. And after our intervention, we found out that people started coming. We also constructed a reconstructive center, surgical center at that place, for the surgical operations that will be performed. Then we renovated the clinics because when there was an existing clinic in that settlement before our arrival. So we renovated the place, we bought new beds and mattresses, and we equipped the place with drugs. And we discovered that people started enjoying all the good things that they are supposed to have in life. Then in addition to that, we employed about 6 people affected with leprosy to work at the facility. So we paid their salary and we give them some other emoluments. We also did another intervention there. The school support program, we supported their children, the children of people affected in that settlement and schooling activities. So we bought school bags, textbooks, school sandals. We gave them uniform, everything free for about 25 children of people affected with leprosy. In addition to that, we also did some economic empowerment at the settlement. We empowered some individuals that can do some minor things there, which included this thing, the shoemaking, welding, tailoring, hairdressing, and some of them also show interest in learning in trading. So we supported them with little amount to start a trade. And in addition to that, we bought equipment. After training those guys at the settlement, we bought some equipment for them to start their business. And presently, I can tell you that at least one of them is the one making protective sandals. For people with plantar ulcer and people with insensitive feet at the settlement. So also, the place, because of our efforts in making the reconstructive surgical center to be of international standard, students of LAUTECH, Bowen University, 𝐷𝐻𝐻, they are now using the Damien Reconstructive Center at the settlement for their training on leprosy, which is the first of its kind in Nigeria. If you visit any of the medical schools in Nigeria as at today, it's only Bowen University Teaching Hospital that take leprosy as a special program before they could graduate. You have to pass through that. It's a special posting. You have to pass through the leprosy settlement before you can graduate. And I believe it's one of our innovations that makes leprosy one of the key subjects to be studied in. So also the students of School of Nursing at the Bowen Teaching Hospital, they also take leprosy as one of their major subjects before they could graduate. So I think those are the, I can say that is a success story, because you need to go there now before our intervention. In fact, it was after our intervention that the place was connected to the national grid. So the local government, they shifted their attention to the place to supply them with electricity. But we are the one paying the bill. We are the one footling the bill on monthly basis. So we pay the bills in collaboration with the Bowen University Teaching Hospital. I mean, both of them, we share the bills and we pay. Then the generator there, we are the one maintaining the generator that supplies the settlement. So also the people, from before now, the place was isolated. Nobody would like to go there to build houses around the settlement. Well, you need to go there today. People have started building mighty buildings there. I mean, the people are now, even because of our intervention, after our intervention, people now, they started going to the settlement to get water from our borehole. From the borehole we sank at the settlement. And people were encouraged, people living in the settlement, we encourage them to go to the community to sell their, because majority of them are farmers. Despite their deformities, they still manage to farm. So their farm products, before our intervention, they don't normally go to this farm to sell, to the town to sell. But now we've encouraged them to go to the farm and to the main market very close to the place, and people buy their products. So I think those are I can say that it's one of our success stories. Per individuals, we have so many of them that have been helped by our organization, and that has really improved their quality of life. In fact, some of them, they left the settlement to live in the community after our intervention. Those we provided with prosthesis, they can now move about. So, and some people, some of them that are old, their children now, they've started visiting them, unlike before. So because they now see the reason why they shouldn't neglect their parents. And the place is now bubbling with life after the intervention. And I can tell you that we have documentary for all these things I'm saying. We have pictures, we have everything to showcase what I'm telling you.
Okay, so sir, what are the biggest challenges you faced on the ground?
Yeah, I think I've mentioned those ones earlier on. I mean, the major challenge is stigma. I mean, it has really affected the diagnosis. I mean, people, they don't want people to know that they are suffering from these two diseases. So it has really affected the diagnosis. Even after diagnosis, the follow-up treatment. I mean, some of them would not like to be coming to the clinic to collect their drugs, or to be seen in the community that they are taking either leprosy or tuberculosis drugs. So that has really affected the treatment outcome to some extent. Some of them will start the treatment somewhere along the line, they will be lost to follow up. So it's one of the big challenges we are facing. The another one is the staff attrition. You know, the local government happens to be the operational level of these the control activities of the two diseases. So we majority of the trained staff. In fact, I can tell you that when we started this program, we had to train all of them. In fact, because without training, because there is a guideline for the leprosy and TB control program in Nigeria, and they have to stick to the guideline. So you need to train people to be able to stick to the guidelines. And we discovered that, I mean, we don't have staff. We cannot pay for staff. It's government that pays their salary. It's government that employs them. So once they reach the retirement age, they have to leave the system. And we are really facing this difficulty in getting people trained. More so, we have a financial constraint. Before now, we are getting huge support from the Belgian government. Now they are now asking us to look inward for funding. If I can tell you that they've really reduced the budget for Nigeria by more than half. So we are now left with little or nothing to manage our programs. So we are sourcing for help elsewhere, especially locally. Maybe if we can get people to support us in achieving some of our majority of in implementing majority of our activities. So another thing that is really affecting our program, although it has improved, is awareness. The awareness about is even better with TB. The awareness about leprosy in this part of Nigeria is, I can say, is zero. In fact, people don't believe that we still have leprosy cases with us. But from our interventions, we know that leprosy, although it's an ancient disease, is now an emerging disease, because we've started seeing children coming down with leprosy. And once you start detecting leprosy in children, there is an adult that is infecting them. So it means we still have huge transmission of leprosy in the environment. People are walking about with leprosy undiagnosed, and they continue to transmit leprosy to people in the community. So I believe those are the major, but the funding and the funding gap, as well as the stigma, those are the two major issues with the program in Nigeria at the moment. And the capacity building. We need to really build the capacity of newly employed staff that are working with us on the program.
Okay, so just as you've said, so what do you think, what are the mental health challenges associated with this disease, such as, just as we discussed, tuberculosis and leprosy?
Yeah, you know that anything associated with stigma, there is always accompanying mental issues. We've noticed that even before diagnosis or before treatment, there is usually majority of our patients, they come down with anxiety neurosis. I mean, they always feel agitated that I believe it's not going to be leprosy or TB. Even if you diagnose leprosy in a patient, you don't tell them directly that you have leprosy, because definitely once you say they have leprosy or tuberculosis, it will tell on their mental status. They feel depressed. I mean, some of them you won't even see them again. In fact, we've had occasions, especially with leprosy, that patient committed suicide because of the stigma associated with the disease. In fact, some have even gone psychotic. We've seen cases that develop psychosis as a result of being diagnosed as a case of leprosy. So those are the things that we are facing. But with our interventions there and there, making life better for them, maintaining the settlements, renovation of the settlements, supporting their children in schools, supporting their health care, supporting them on economic empowerment programs, we have noticed some changes in their quality of life. They now have hope that everything will be okay in future. So we have so many success stories, from hopelessness to happiness. We have some testimonies here and there.
So do those challenges actually look different in rural areas compared to cities?
Yeah, in cities for TB, in cities for TB, overcrowding, poor housing, it fuels the TB. So in some slum areas in cities, in fact, if you go to Lagos, we see a lot of cases in slum areas. Where we have many people, maybe like 10 people living in one room, and the closeness is there. So people can easily go down with TB in rural areas. And for treatment, people pay out of pocket to access treatment in urban centers. Cost of transportation is number one. Cost of feeding, because once you are being managed for the two diseases, you need to take an adequate diet. So to get enough food, people need to make a lot of efforts here and there to be able to take their distance. So, for follow-up too, in fact, TB drugs has to do with daily intake of drugs because of the nature of the drugs they are using. And that's why, because of these out-of-pocket expenses, we shifted from daily visit to the clinic to community approach. So they now take their drugs in the community under supervision of a treatment supporter. So we need, because anybody taking TB drugs must be supervised. We must ensure that they get their drugs daily under the supervision of a volunteer. So these are the things we do in urban setup to ensure that they get. But for rural, the problem is more, because number one, the accessibility issue. In some places you can't find any health center there. In fact, if there is any existing health center, there is no staff to man the place. So they have to trek before they could they will go distance, to some other places to access treatment. So another thing is the road. The road, especially in the rainy season, because I was a TB program manager in Lagos. In fact, I started the TB program in Lagos. And it was all those riverine areas, those rural riverine areas. We take canoes or speedboats to reach the place for outreaches, even for follow-up. We need to. So working in rural setup, we face a lot of issues. Even the laboratory facilities is not available where you can make a diagnosis. Because for TB, you need laboratory services, which is not available in those hard-to-reach areas. So you collect the specimen and ship it to other designated facilities in the town. So the electricity supply, even if we want to establish a laboratory in the rural setup, there is no electricity to power the microscopes or the gene experts that we use for diagnosis and for follow-up investigations. Even X-ray too, some of them that needs X-ray. Although presently, with the support of Global Fund, we now have mobile X-rays, battery-operated X-rays that you can take to rural areas.
Communities.
But you still need logistics. If you want to go to visit any rural area, you need logistics to be able to achieve your this thing there. So for leprosy program in the rural, you always find it, because you know leprosy, there is this associated stigma. So you see a lot of them in the bush, in the rural setup. You see a lot of leprosy, although they still live with us in the community, urban setup. But in those places, they are being undiagnosed. So and majority of them in the rural areas, they believe, because of their level of education, they believe that most of TB and leprosy are caused by witches and wizards. Yeah, this cultural belief is stronger in rural setup than urban. So to convince them to come out and take your treatment, we always find it very difficult. So we have a lot of patients lost to follow up in rural setup. So I think that those are the things I can remember for now.
Thank you so
But
much, sir.
the two diseases are easier to be managed in urban setup
compared to rural. Thank you very much, sir, for that. Okay. So I was going to say that you don't work alone. How closely do you collaborate with the Nigerian government and local partners?
Yeah, you know, 𝐷𝐴𝐻𝐻 Foundation Belgium they were invited. In fact, I can tell you that all partners working on the two diseases, they were invited by the federal government. So without signing a memorandum of understanding with the federal government, you can't work in Nigeria as an NGO. So our first partner is the government, at the federal, at the state, and at the local level. So we signed memorandum of understanding with the government at the three levels. And we also partner with WHO, because we have some activities that we cannot do without support from WHO. We always know it's an international organization. I mean, so occasionally there are some activities that they have to key in. So we also partner with WHO. Then we also partner with HILEP members. HILEP, they are anti-leprosy organizations working in Nigeria. We are 4 in number. So we partner with them to achieve some of to implement some of our activities. So also we partner with missionaries. Like the 𝐷𝐴𝐻𝐻 program, what I've mentioned earlier, it was the settlement. The Bowen Teaching Hospital is under Baptist missionaries. So we were invited in conjunction with the state government and the local government to come and assist them at the settlement. So without them giving us the go-ahead, we can't enter their territory. So we also, in some other states, ECWA, some other missionaries, Catholic, we partner with them. Then the community-based organizations, the TB Network Nigeria, and the states in which we are working in. So we partner with them. Then people affected with leprosy, they also have their own association. So we also partner with them. Students, today, the students of University of Ibadan, they have a group. They call it Friend of 𝐷𝐴𝐻𝐻 Foundation. So they support us in doing active case search for TB as well as leprosy. Then we also partner with the Association of Dermatologists, because leprosy is a skin disease with associated nerve impairment. So we also partner with dermatologists, Association of Dermatologists, especially in Lagos. We work hand in hand to see that we get cases. So also we partner with religious, I've mentioned that, the opinion leaders in the community. So there are also then higher institutions, like I will cite University of Ibadan. In fact, we've been, and University College Hospital, we've been partners for long in the area of MDR, multi-drug resistant TB. In fact, we constructed a research lab at the University of Ibadan. The building was constructed by the 𝐴𝐻𝐻 Foundation. It's a genomic laboratory. It's one of the current things in the TB world. So it was constructed solely by the 𝐴𝐻𝐻 Foundation and equipped with modern diagnostic equipment by our organization as well. So I think those are the people that the organization and the people we partner.
So, sir, from these partnerships, are there still gaps that need to be addressed?
Yes. You know, when you work with so many partners, with different programs, with different ideas, there is bound to be some issues. I can tell you that repetition of activities is one of the key things that we noticed. When you are doing the same activities with another organization, it's something that can rear its head at any moment. So then number two, the timing of activities. If I want to partner with you and we didn't agree, you decided, okay, this thing, we have time in the morning. Another organization will say, I don't have time in the morning. We can only do this thing in the afternoon. So clash of time, when an implementation can take place, is also one of the key issues that normally, then, I think those are the major gaps. But I believe partnership is a good, it's a good business. If you want to achieve a lot, you need to partner with some people to move forward.
Very true. So are there any innovative strategies or technologies helping you reach more people at the moment?
Yes. We are now engaging the community people to work for us. They work for us in support of Global Fund. In fact, we started the initiative in Lagos, Community TB Workers. They work, they go about, they do active case search. They move from one house to another to look for people who are coughing. And once they are able to identify them, they collect their specimen. And they take the sputum riders will now take the specimen to the laboratory for diagnosis. And they also support the program in management, in the treatment of those who are positive. Then they also help us to trace the contacts. So we do a lot of contact tracing for both TB and leprosy. Because if you detect a patient and you treat, and the patient now goes back to the same environment where he was infected, if you don't treat the other ones in that environment that can reinfect the patient, it means you have not done anything. So contact tracing happens to be one of the key activities that we embrace in our organization. So then I've mentioned the dashboard. It's also one of the things, because before that innovation of real-time monitoring of sputum shipment, everything was in a mess. They might collect sputum, and the sputum will not get to the laboratory after 1 week. And one thing about sputum in TB is that once it fails to get to the laboratory on time, then you won't be able to see anything in the sputum again. So the real-time monitoring from the time of production to the time it gets to the lab is one of the things that has been showcased internationally. It was adopted at one of the international meetings, and I can tell you that the innovation was adopted by the national program. It's now what operates all over the country. So, in fact, a TOT training of trainers is going on right now at our backyard at 𝐶𝐶. And I can tell you that it's 𝐷𝐀𝐻𝐻 Foundation that is facilitating that training, supported by the Global Fund. So I think those are the care after care innovations. The mobile clinic initiative is also one of the innovations that is being applauded internationally. At least we've been able to improve their quality of life by taking Medicare to their doorsteps in the settlements.
So all of this that you have mentioned that you are doing in Nigeria, sir, do you think they can be replicated elsewhere?
Yes. 3 years ago, the national program in Burundi, they visited us in our office here to get some information about how to implement some of these activities I've mentioned earlier, the active case search, the sputum dashboard program, and the care after care activities in leprosy. I think, the sputum dashboard thing emanated from our office when I was in Lagos. In fact, I started this program with the support of my team in Lagos, in Nigeria, in 2018. And it has been adopted nationwide. So I believe, and people from other countries, they also want to come to Nigeria and learn this, how to operate the sputum dashboard and the issue of sputum shipment with the use of the sputum dispatch riders is also some of the things we can. Then some of our care after care activities is also being copied elsewhere. The mobile clinic approach initiative is there for people to then the issue of establishment of a reconstructive surgery center, which they can also, especially in the north, where they are also asking us that, they have a lot of Hausas, the northerners, with amputated, with deformed limbs, and that can benefit from reconstructive surgery. So they are also looking forward to a day when they will have things like that in that part of Nigeria. So those are the things that can be replicated elsewhere. We have so many things that is being done, like the management of the RTB. We started at UCH, and it has now, it's now all over the country.
Awesome, sir. So, wonderful work. So for people watching and listening, what can they do to support your work?
Yeah. I mentioned this earlier on, that the issue of funding, this is a key issue that needs to be addressed quickly, because we were informed by the headquarters with the Belgian government, the 𝐷𝐀𝐻𝐻 Foundation Belgium, that very soon they will no longer support the program in Nigeria, and we need to start our sustainability plan. In fact, we started years back, but we really need to reactivate it, to make it as a point of duty to look for donors, either individually or corporate organizations. And we've started doing that last year to get funding locally. So that, as they say, there's this popular adage, little drops of water makes a mighty ocean. Even if somebody gives you 500,000, even 1,000 naira, it goes a long way to achieve some of these things that we've planned to help people So donation, is key. Yeah. Then the number 2 thing is the fight against stigma. In fact, we need people to support us in the fight against stigma. We want people affected by leprosy to be part of the community. This inclusion thing, they should be included in all social activities in the community. In fact, if you want to get married now, if somebody now hears that your father is somebody that is affected by leprosy, they will say bye-bye. They won't give their child to enhance for marriage. Work, people cannot employ them. They can't attend schools. So we need to really do something fast. So we need people to support us in this fight against leprosy. And so also poor awareness. For TB and leprosy, we really need to improve on the awareness. People can also support us in creating awareness in the community about TB and leprosy. So those are the 3 things I can think of at the moment.
Very important.
Yeah.
Okay, sir. So looking ahead, is Nigeria really on track to eliminate this disease?
Yes, we are. I can tell you that with our achievements so far, we've been able to raise the level of awareness, to some extent. And then the issue of case detection too, it has improved. Before now, our case detection activities is on the very low side. We are really not detecting cases as expected. But with things here and there, innovations here and there, I think this has also so improved. Then the issue of case holding, making patients to start treatment and end as at when due, is also that we have noticed improvement on this. So I think we have really achieved to some extent, but we still need to do more. To be able to get to our target. Sure. And the target is 0 transmission of TB, 0 transmission of leprosy, so that we can achieve our vision of a future free of TB and leprosy in Nigeria.
So you mentioned a lot of challenges. Amidst all of these challenges, what gives you hope?
Yeah, I believe with the support of government and corporate organizations and some philanthropists, I think we can still achieve. We can still support people affected by the 2 diseases.
Any parting message for the team at Ferdinand Foundation International?
Yeah. Damien Foundation, as an organization in Nigeria, we are very grateful for your interest, for the interest of Ferdinand Foundation in supporting TB and leprosy activities in Nigeria. We look forward to a future collaboration with your foundation in reducing or even eliminating the 2 diseases from our community or from Nigeria as a whole. Thank you.
Important work and important conversation. Thank you so much for speaking with us today. And thank you for your impact so far.
Okay.
Thank you.